Hello, everyone. Welcome to the workshop, Can a Stem Cell Transplant Cure an Autoimmune Disease? My name is Tom Stewart, and I will be your moderator for this workshop. It is my pleasure to introduce today's speaker, Dr. Ernesto Ayala. Dr. Ernesto Ayala is a hematologist-oncologist in the Department of Internal Medicine at Mayo Clinic Hospital in Jacksonville, Florida. He specializes in transplantation for the treatment of benign and malignant hematologic conditions and the treatment of lymphoma. He also applies new immunotherapies, including CAR T-cell therapy, for the treatment of advanced lymphoma, and has interest in the use of autologous transplantation for the treatment of severe autoimmune disorders such as Scleroderma and multiple sclerosis. Please join me in welcoming Dr. Ayala.
Thank you, Tom. Thanks for the kind introduction. As you said, I'm a bone marrow transplant doctor. Over the past 5 years, I've been working in patients with severe autoimmune disease, and it has become a very important part of what I do on a daily basis. I have nothing to disclose in reference to this presentation. This is the outline of my presentation today. I'm going to go briefly over what we believe is the origin of autoimmune disease. Now, what is the current treatment, the standard treatment of autoimmune diseases? What type of transplant to use? Do we use an autologous transplant or do we use an allogeneic transplant for autoimmune disease? How does an autologous transplant work in patients with autoimmune disease? What autoimmune diseases can be treated with an autologous stem cell transplantation? What factors determine if a patient with autoimmune disease is a good candidate for transplant? And at the end, I'm going to go over the short and long-term risk and side effects of autologous transplantation. So it's a long agenda. Let's see how it goes. So let's start from the origin of autoimmune disease. In this graphic, this is a bit of a summary of how we believe autoimmune disease starts. So we see on top, HLA, cytokine pathways. This is all inheritance. These are all factors that are inherited. And this is just to say that there's a strong familiar tendency to develop autoimmune disease. If a person has an autoimmune disease, family members will have an increased risk of developing another one. At the bottom, I wrote, or it says defective regulation. So there seems to be a defect in the way the immune system works in patients with autoimmune disease. There seems to be some discoordination in those cells. But there is always, I said here, environmental triggers. There seems to be always a trigger. Even with inheritance, even with defective regulation, you need a trigger. Common triggers for autoimmune disease are infections, traumatic insults, as it says here, microbiome, which is changes in the normal bacterial flora in the bowels. So there seems to be something that triggers the reaction. I added a fourth arrow here that says sex. As you're going to see later, autoimmune diseases are far more frequent in women than in men. So there seems to be a strong influence of hormones in the development of autoimmune disease. Here you see the final consequence of this process is the generation of auto-reactive T cells. Remember, the most important cells in our immune system are the lymphocytes. They are the ones that direct the orchestra, let's put it that way. So here we have some lymphocytes some of the T lymphocytes and some of the B lymphocytes that grow, expand, become auto-reactive, and start causing tissue injury, tissue damage. This is the final pathway for autoimmune disease. Some clinical characteristics. So as I already said, they are predominant in women. Most autoimmune diseases, the ratio of female to male is about 3-to-1, 4-to-1, sometimes even up to 9-to-1, for example, in lupus. In all autoimmune diseases, there is damage to the tissues that is mediated by cells, the lymphocytes, macrophages, and other cells, and antibodies. So the B lymphocytes produce what we call autoantibodies that target and cause damage. They can affect any organ system. So we have neurological autoimmune diseases, gastrointestinal, rheumatological, endocrine, and there are some other more. When we talk about autoimmune diseases, we have some of them affect one specific organ. For example, there is something that we call Hashimoto's thyroiditis. The only organ that is affected is the thyroid. And also here you see multiple sclerosis, MS, in which the target is the myelin protein. Well, the myelin is actually a lipid that is present in the brain and the spinal cord. So the damage is in the brain and the spinal cord. But there are some other diseases that affect multiple organs in the body, like scleroderma, lupus, Crohn's disease, rheumatoid arthritis. They can affect the joints, they can affect the lungs, the heart, gastrointestinal tract, and some of the elements of the blood, red cells, platelets. They are all affected or destroyed by the disease. A brief summary of the treatment: steroids, corticosteroids like prednisone, dexamethasone, and so on, are commonly used in autoimmune disease. They rapidly cut the inflammation, and they are helpful to control a patient that has a crisis, an autoimmune disease that is flaring. But they are not helpful for long-term treatment. Now we have immunosuppressive medications. Several medications, these are oral agents that depress the function of the immune system, and they had to be taken for months, for years. More recently, now we have the disease modifiers. These are antibodies that target specific pathways that activate the immune cells. These have revolutionized the treatment of autoimmune disease. You see them in TV, they're being advertised all over for Crohn's, for lupus, for everything. They are very useful, but they have several limitations. They are very expensive. They have to use continuously, not stopping for many years. And that's what I wrote here. All these treatments must be done for many years, frequently, lifelong, to keep the disease under control. But there is always the risk of breakthrough. Even with the best possible treatment, the disease is resistant, resilient, and breaks through. Now, what type of transplants do we use for autoimmune disease? So here it's important. We have allogeneic transplantation. It's when we use a donor. We use a different person, and we take stem cells from that donor. You think about it, this is a definitive therapy. Why? Because when you give a patient a new bone marrow from a donor, you completely replace the immune system of the patient by a new one that comes with the donor cells. So definitely you will eradicate the autoimmune disease. The actors of the autoimmune disease are gone. Um, However, we don't frequently use this type of transplant. And the main reason is it carries a much higher risk. There is a risk of mortality. And in the specialties, you talk to the specialties, the doctors in rheumatology, in neurology, they would never send the patients for us for donor transplants because they would believe that is just too risky. On the other side, we have autologous transplantation, which is when we use the patient's own stem cells. We use that to reset the immune response of the patients. It has a much lower risk and is effective in the majority of patients. And I'm going to expand on that, and most of what I'm going to say from now on has to do with autologous transplantation. The mechanism of action of autologous transplant in autoimmune disease. The final goal is to reestablish what we call self-tolerance. Our immune systems are tolerant to our bodies. They should not attack our bodies. So what we're trying to do is to reestablish that self-tolerance so that there is no injury to our organs. How do we do it? We essentially destroy all the pathogenic auto-reactive immune cells. We destroy the cells that are causing the problem. And that leads to an immunological renewal. So we get rid of all the lymphocytes that are causing the problem, and the patient generates new ones. We call them naive ones because they have not been exposed to the organs of the patient. So we generate new naive T and B lymphocytes that will not attack the organs, and in that way the disease will become dormant. But there are more other things. So the thymus is a gland that is a critical part of the immune system. It's like the high school of the immune system. All the cells go there to be trained about what is self, what to attack and what not to attack. So there seems to be reactivation and improvement of the thymic function. And we also reestablish these regulatory T cells. These are lymphocytes that regulate the activity of the immune system. Stop these cells when they are doing too much, or they stimulate them when they are doing too little. So we reestablish these regulatory T cells. So all of this together leads to an immunological renewal and what we call a reset of the immune response. This cartoon shows a bit of that again. This is what I already said. The patient gets the conditioning regimen. Here in blue it says Cy plus ATG. This is the week before the transplant. Then patient gets the infusion of stem cells. I'm going to expand this later. And here you said that in the first part there is recovery of the granulocytes, then generation of new lymphocytes, naive lymphocytes, thymic reactivation, reconstitution of the new immune system that is going to be tolerant, and the disease will stop. So how do we do an autologous transplant for autoimmune disease? So in many ways it's similar to any other autologous transplant. The first step is the pre-transplant assessment of the patient. So we do testing of the heart, kidney, liver, lung. We put special attention to fertility preservation because these are all young patients in fertile age. So this is very important for us. We try to protect fertility as much as we can. There is always a psychosocial assessment, and then there are some disease-specific assessments. For example, if a patient has multiple sclerosis, we want to do MRIs of the brain and the spine to see how the disease is how affected the brain is at the time we do the transplant. Or if we are doing a patient with Crohn's disease, we want to do a colonoscopy and see what is the status of the disease. And that's why I call it disease-specific assessments. Here on the right, you see the mobilization and harvest of peripheral blood stem cells. So we give patients some injections that expand and mobilize the stem cells outside the bone marrow into the bloodstream. And then we use a machine that you see depicted here, and this machine will do the job for us. This is a pheresis machine that will harvest the cells that we need from the bloodstream of the patient. This is all outpatient, it's very simple and very well tolerated. And this is the real transplant. So this is the timetable in the hospital. Typically, patients stay in the hospital 2 to 3 weeks. During the first week, you see here day -5 to day 0, patients get the conditioning regimen. The conditioning regimen is a combination of chemotherapy, sometimes low doses of total body irradiation, and antibodies, all of this to destroy completely the immune cells of the patient. Here on top, you see this is the most common combination that we use, but there are several variations of this. So the most common combination is a chemotherapy agent called cyclophosphamide and a cocktail of antibodies from rabbit ATG. So all of this is infused in the first week. Patient is already in the hospital. We monitor the patient closely for reaction during the infusion. Then at the end of the week, the patient gets the cells that we collected. Why do we give the stem cells back to the patient? Well, this chemotherapy, this conditioning regimen partially destroys the bone marrow of the patient. So we give these stem cells back to help regenerate the bone marrow function of the patient and rapid recovery from the process. In the second week is when we see some of the acute problems or some of the side effects from the conditioning regimen. So first of all, and the most important one, patient is going to have extremely low blood counts. Very low white cells, very low platelets, very low red cells. Many patients will need transfusions. Some patients develop fevers. There is a high risk of infection. Many patients will need antibiotics. We could see inflammation and damage to the oral mucosa, the lining that covers the mouth and the bowels, and sometimes diarrhea, but this is far less common than when we do transplants for blood cancers. And typically around day 10, there is recovery of the blood counts, and somewhere around day 12 to 15, patients get out of the hospital. In our own experience, it takes 12 days from the time that we infuse the stem cells to the time that the patient gets out of the hospital. What autoimmune diseases do we treat with autologous transplantation? So the list is long. This is a lot longer than what you see here. However, so I put them in 3 groups. There are neurological diseases. By far, the most common one is multiple sclerosis. This is the most commonly treated disease around the world with autologous transplantation. There are some others: myasthenia gravis, stiff person syndrome, neuromyelitis optica, and some others. Rheumatological, the one that is most commonly transplant is Scleroderma. But transplant has been used for patients with lupus, inflammatory myositis, rheumatoid arthritis, Beckett's disease, vasculitis, and others. And in gastroenterological autoimmune diseases, typically we treat Crohn's disease. Now I'm going to dedicate the rest of the time that I have to multiple sclerosis, Crohn's disease, and Scleroderma. Multiple sclerosis. This is the most common cause of neurological disability in young adults. The median age of diagnosis is 30 years of age. 3 times more common in women. So we have young women in the most productive time of their lives being affected by a devastating disease. There is an immune attack of the myelin, which is a protective cover. You see here, this in yellow, this is the myelin that covers the axons of the neurons. The axons transmit the impulse from one neuron to the other. So there is damage and breakdown of the myelin. The axon is exposed, and eventually with that, the axon is damaged and the neuron dies. It causes progressive neurological disability, loss of function. So these are patients that lose their ability to walk, sometimes to talk, sometimes blindness. And the final result, patients lose their jobs, and they require a lot of care, and they have to just stay at home. Here you see the typical white plaques in the brain. Is the most common indication for autologous transplant in autoimmune disease. It has been used for 20 or 25 years. There are many published series, and hundreds, probably now thousands of patients have been treated. There has been one prospective comparative trial, a head-to-head trial, in which transplant was compared with the best available therapy. And based on all this data that has been accumulated over the years, the American Society for Transplantation and Cellular Therapy endorses autologous transplant as an efficacious and safe treatment for active relapsing forms of multiple sclerosis to prevent clinical relapse, MRI detectable activity, and worsening disability. So here they want to highlight these relapsing forms. The relapsing forms of MS are the early stage of the disease, typically in the first 4 or 5 years of the disease. This is that clinical trial, the MIS trial, a prospective comparative trial. And in this graphic, you see months. So this is time, and this is the proportion of patients with progression. So you see here, in patients that got a transplant, in yellow or orange, it shows that by 5 years, probably 10% of the patients have progressed. While those who didn't get a transplant, close to 80% of the patients have shown progression. And this is a different way to show the same. It is time to first relapse. When patients start relapsing in disease-modifying therapy versus those who got an autologous transplant. So the efficacy of transplant is very clear and very obvious. This graphic shows here at the bottom, you see the proportion of patients with NEDA. NEDA is no evidence of disease activity by clinical assessment and by MRI imaging. So you see after 2 years of therapy, these are all the therapies in the market. Well, not all, there are a few new ones, but the most active ones are these antibodies here. And then you see that at 2 years, only around 40 to 50% with the most effective agents, only 40 to 50% of the patients remain with no evidence of disease. And these are all the sum of the published theories in transplantation. The proportion of patients free of disease fluctuates between 70 to 95%. So in summary, autologous transplantation is effective in most patients with multiple sclerosis. It's more effective than standard disease-modifying therapies. It is most useful in the early stages of the disease, the relapsing, remitting, inflammatory first 4 or 5 years, before a patient has accumulated neurological damage or progressed to the late degenerative phase. It induces remission that may last decades. It's a one-off treatment. One treatment and the patient is on remission and doesn't need any more treatments for MS. There's still a risk of relapse over time that has been as high as 20%. Now changing gears, scleroderma. Scleroderma is a rare rheumatologic disorder. We also call it systemic sclerosis. It's characterized by vascular damage, extensive organ fibrosis. This fibrosis is the core of the disease, the deposition of scar tissue in multiple organs of the body. And that leads to progressive organ injury. So here I show some of the features of scleroderma. It's hard to see here, but the skin of this patient is extremely thickened. And you see it's like bright. And the result is patient loses mobility, the ability to use the joints. And if the patients are not able to close their hands, they're not able to grab or manipulate objects. And that rigidity of the skin progresses all over the arms, the legs, the torso, and it's extremely incapacitating. Here it shows interstitial lung disease, progressing deposition of scar tissue in the lungs. Here is what we call Raynaud phenomenon, which is the small arteries in the fingers closing and there is no flow to the fingers, and that's why they are white. So the hallmark is progressing fibrosis that affects the lung, heart, and several other organs. But these are the two that cause the mortality. Patients die of lung and heart fibrosis. There is also renal dysfunction, gastrointestinal involvement with malabsorption and malnutrition. Literally, the patient is trapped in its own body. Is all this scar tissue in all the organs of the body. And the mortality, even the best therapies, is as high as 30% by 10 years. 3 prospective comparative studies, you see the names here, all these fancy names, proved that autologous transplantation is superior to the best available therapy. And the American Society of Bone Marrow Transplantation endorses autologous transplant as standard of care, should be used in every patient with scleroderma that fails standard treatment. So after a patient is treated properly, 1 or 2 lines of therapy are not working, the patient must have a transplant to prevent the progression of the disease. Autologous transplant stops the disease in its heels, allows organ healing, improves quality of life, and induces long-lasting remissions. This is just some of the prospective comparative trials, the ASTIS trials. You see, this is overall survival. So the mortality, by doing a transplant, the mortality, the rate of dying from the disease was decreased. This is the group that didn't get a transplant versus those who got a transplant. And this is another trial. This is the Scott trial. This is the American, a multi-center American trial. That shows here the same. Transplantation was far superior than compared to cyclophosphamide in overall survival and in event-free survival. So in summary, patients with scleroderma that receive autologous transplant, many more will survive the disease and many more will have long-lasting remissions with improvements in quality of life. And you can see many patients that literally came on wheelchairs, and now they come back to normal life, and even many of them go back to work. Finally, Crohn's disease. Crohn's disease is a very severe autoimmune inflammatory disease of the gastrointestinal tract. Most commonly affects the colon and the ileum, which is the last portion of the small bowel. It causes extensive ulceration of the organ, patches of ulceration throughout the colon and the small bowels. And that leads to diarrhea, malabsorption, fevers, weight loss, and poor quality of life. Here you see the normal lumen of the bowels, and this is in a patient with Crohn's. You see how the bowel is inflamed and the lumen is narrowed. But not only that, this is complicated by the formation of abscesses. There is perforation of the bowel, and these are abscesses, collections of pus. And also fistulas, which is the formation of small tunnels that go across the tissues all the way to the skin. And all of this leads to surgeries. These patients end up requiring frequent surgeries to resect affected segments of the bowel with progressive loss of bowel segments. I didn't show all the results of the trials, but there have been several trials in Crohn's disease, and it can induce long-lasting remissions free of therapy in a large proportion of patients. However, the risk of relapse in Crohn's disease is much higher than in patients with scleroderma or multiple sclerosis. So by 5 years after the transplant, somewhere around 3/4 of the patients will have relapse. However, patients who relapse respond much better to many therapies that they have failed in the past. So the disease behaves in a different way, in a much more benign way after the transplant. And still, the benefit in quality of life and control of the disease persists. So, can an autologous transplant cure an autoimmune disease? It's not entirely clear yet. Many patients have remained in remission for more than 10, 15, even up to 20 years, free of disease and free of therapies. Are they cured? So we really don't know. But we know that after 15 or 20 years, many of them remain in remission, not requiring any therapies for the primary disease. Who is a good candidate for a transplant in autoimmune disease? So unfortunately, most patients are sent to us as a last resort when everything has failed. So many patients have accumulated irreversible damage, and many patients are malnourished, and many patients are very weak and debilitated. We don't want to see that. We want to see patients in the first 5 years of the disease, before the disease has caused extensive damage. And in patients in scleroderma, even sooner, because in scleroderma, available therapies are very weak. They fail in most patients. So the patient should be free of any other major medical problems. So we cannot transplant a patient with severe heart disease or lung disease. We have to be very careful to make the transplant safe. Also, what we recommend is early consultation with the transplant physician, with experience in autoimmune disease to establish if the patient is a good candidate. And here there is a lot of teamwork. We have to work together with the referring specialists, the rheumatologists, the neurologists, the gastroenterologists. There has to be a close collaboration, an interdisciplinary collaboration to decide who is the right patient and when is the right time for the transplant. Sometimes we need to decide what therapy the patient needs before coming to transplant, and how we're going to follow the patient after transplant. This is all multidisciplinary. Risk of doing a transplant, short-term effects of autologous transplant for autoimmune disease, most of them occur in the hospital. When the patient is in the hospital, blood counts are very low. There is a high risk of infection. Some patients develop fevers and need antibiotics. There is some risk of organ injury. Sometimes we see instances of pulmonary edema and other problems. Sometimes irritation of the mucosa, enteritis. So we deal with this during the transplant, the hospital stay. After discharge, patients are still weak, but they rapidly recover. The patient is still immunocompromised for at least 3 months because the immune system was reset and starts from zero, so it has to regenerate. And it has been in a few series, patients develop a second autoimmune disorder. This has been noted in some of the publications, but this is very rare, probably in 1 in every 100 patients. Long-term effects, certainly the one that is most feared is the recurrence of the autoimmune disease. This is a very small risk of secondary malignancy, a blood cancer that can be triggered by the chemotherapy. This risk is far more important when we do autologous transplants for blood cancers. In autoimmune disease is very, very rare. But this is also common. There is slow recovery. Patients come to transplant, they were already very debilitated, we already had many problems. So even if the transplant goes well, patient will have a long time to fully recover and go back to a normal life. So they need rehabilitation, physical therapy, occupational therapy. But with proper support, patients recover and go on with their lives. So in summary, autologous transplantation induces long-term remissions in most patients with autoimmune disease. Proportionally, the duration of those remissions depends on the primary disease, the number of previous therapies. We see in most patients a major improvement in quality of life. We see those patients that come to us literally in wheelchairs, and we see patients going to normal lives and patients going back to work, to productive life. Careful patient selection is critical to make the transplant safe, and it works much better in the early phase of the autoimmune disease in the first 5 years, and that's how we like to do them all. And there is always, it is critical to have a close collaboration between the transplant specialist and the referring physician. And I think that was the last one. Thank you very much to all of you for listening, and I'll be open for any questions.
Thank you, Dr. Ayala, for the excellent presentation. So let's get to the questions now. If you have a question for Dr. Ayala, please use the chat box on the left side of the screen to submit your question. We will answer as many questions as possible. Our first question comes from a patient who says, my husband is 155 days post-transplant for Wiskott-Aldrich. What, if any, experience or knowledge do you have with Wiskott-Aldrich, and whether or not it is cured with a transplant in an adult?
Wow, you really hit me with a difficult one. So Wiskott-Aldrich is an extremely rare disease, an extremely rare immune disorder. I suspect he probably got a donor transplant, an allogeneic transplant, not an autologous one. So in any immune disorder that the patient receives a donor transplant, the patient will acquire a new immune function that comes with the marrow cells from the donor. Effectively, that will replace the old immune system of the patient and cure the disease. But this is a very unique and rare entity.
Okay, thank you. Another question from another patient says, I had an autologous stem cell transplant for multiple myeloma a year ago. I also had alopecia areata prior to my cancer diagnosis. Is it possible that I won't see a recurrence of the alopecia since the stem cell transplant that I had last May?
Yes, So that's another very interesting point. One of the ways we learned that autologous transplant works is because patients who were having autologous transplants for blood cancers and at the same time had autoimmune disease, they saw long remissions of the autoimmune disease. So I don't know of data of alopecia areata, transplant for alopecia areata, but I can tell you that if the transplant was successful, there is a good chance that the alopecia will remain on remission for a long time.
Thank you. This patient wrote a question having to do with fecal microbiota transplantation. They want to know if you have any comments on using fecal microbiota transplantation to treat autoimmune diseases. And they give a reference to a research paper, Fecal Microbiota Transplantation, Emerging Applications in Autoimmune Diseases.
Yeah, so the talk that I did today was using autologous stem cell transplantation. So fecal microbiota has been tried. In particular, for example, in gastrointestinal disorders like Crohn's disease, but also in some other autoimmune diseases. And it's all based in the fact that maybe by providing a normal microbiota, we have an equilibrium with the bacteria that is inside us. And we're trying to reestablish that equilibrium if it is damaged by using microbiota. So I can tell you that the data is limited, that the data is still developing, and this has not been widely used for autoimmune disease. So I would say the jury is still out.
Okay, thank you. Recent studies have shown that butyrate production and consumption are imbalanced in rheumatoid arthritis, and that the immune status and joint symptoms of RA model rats can be improved by dietary butyrate supplementation. Is long-term supplementation of butyrate recommended for the improvement of autoimmune disease?
No, it is not a standard treatment. There may be some data. You probably would need to ask specifically a rheumatologist if that type of diet works. But as a stem cell transplant doctor, I probably would not be the person to answer that question.
Thank you. Moving on to the next question. How is it determined whether an autoimmune patient is a good candidate for transplantation?
Yeah. So first of all, we don't want the patient to have accumulated a lot of damage from the autoimmune disease. So we don't want to see patients, for example, in multiple sclerosis. If a patient already lost vision, cannot walk, has already lost a lot of function, it's probably just too late. So the first thing is to try to make sure that we see the patients in the early stages of the disease. The second part has to do, is it transplantation safe for this patient? So that's when we do the pre-transplantation workup, the pre-transplantation assessment. As I explained, we do extensive testing of the heart, lungs, kidney, liver. We want to know what infections a patient has been exposed to. So we do this extensive pre-transplant assessment to see if it is safe to do a transplant in a specific patient. So those are the two major components. Make sure that the disease is not too advanced, and second, that the organ function of the patient is appropriate to proceed.
All right, thank you. Another question, are transplant outcomes different for autoimmune patients compared to cancer diagnosis?
Yes, that's a very good question. they're different because here we're treating two completely different diseases. I do many transplants for lymphoma and for myeloma. Those are blood cancers. And we try to induce long-lasting remissions in those patients. So here we're not trying to avoid organ damage or organ injury. We're trying to keep the patients cancer-free. But in autoimmune disease, what we're trying to do is to stop the progression of organ damage, make sure that the lungs, the heart, the kidneys are no longer damaged by the autoimmune disease, and in that way, reestablish quality of life and reestablish functionality. So the goals are different. But yes, autologous transplantation is effective either way.
All right, thank you. I will say at this point that we only have a couple of questions left, and we can go through them, but if there is anyone in the audience that wishes to ask another question, please put it into the chat box, because I still think we have a few minutes to go over any other questions. So I'll go to the first of the remaining questions now. What are the chances that my lupus will go into long-term remission after the transplant?
That's a very good question. I didn't present data on lupus, but there is a good number of publications using autologous transplantation for lupus. Collectively, you put them all together, somewhere around 60 to 70% of the patients with lupus can expect a long-term remission from the disease after an autologous transplant. Now, what happens in lupus, there have been many new antibodies and disease modifiers, so we don't see many patients with lupus referred to us. And now we have, it's worth to mention, now we have CAR T-cell therapy, a new type of immunotherapy that is jumping into the arena of autoimmune disease and has been used in lupus with excellent results. So, yes, autologous transplantation is effective in patients with lupus.
Okay, thank you. Another question here. I have AML and will have a stem cell transplant this summer. I also have rheumatoid arthritis. Will my RA be gone after my stem cell transplant?
So, very, very good question. I think there is a very good chance that your RA will disappear. And the reason is very simple. Your immune system that is causing the disease will be replaced. And will be replaced by a new immune system, by a healthy one coming from the donor. So with that, the disease is expected to disappear. Now, you could still have some residual joint pain or a little bit of discomfort because of what the RA already did, the damage that is already established in your joints. So that will persist. But the inflammation and the presence of the diseases itself should disappear.
Thank you. Finally, our last question here is, I have Crohn's disease. When should I consider a transplant?
Yeah, this is a very good question. One of the most important questions to me. The patients that we have seen for transplantation with Crohn's disease, they all have seen 10, 15 years of disease. And when they come to us, many of them have lost their colon. Some of them have an open stomach outside the body because they lost extensive portions of bowel. So the disease has been relapsing for years. So they use a new antibody, the disease sort of gets in remission and then comes back, and they go on and on and on. So as I said, the best results of autologous transplantation are when it's used early. So in patients with Crohn's disease that have received the best available therapy out there, including at least 2 disease-modifying antibodies. If they relapse after at least 2 disease-modifying antibodies, they should be referred for an autologous transplantation.
Thank you. We just have one last comment from a member of the audience who says, "Thank you, so informative." And I must agree. And on behalf of BMT InfoNet and our partners, I would like to thank Dr. Ayala for an excellent look, an exciting look at the future of transplant and autoimmune diseases. And thank you, the audience, for your excellent questions. Please contact
Thank
BMT
you all
InfoNet,
for your attention.
and please contact BMT InfoNet if we can help you in any way. And please, we hope that you enjoy the rest of the symposium. Thank you.